Okay, can you can you hear me now?
Yes, we can. You're good.
Okay, so I'll
Oh,
audio on my phone and video, however.
perfect. All right. I'm going to ask folks to mute just for a brief moment so I can kick us off. Thank you, folks, for joining. We have people still trickling in. I usually give a couple of minutes while I'm doing my housekeeping blurb, but I won't take too much time before I turn it over to our speakers today. Thank you so much for joining us for the final webinar in our series for HPN Awareness Week. It has been a very full, busy week, and I hope folks have learned a lot and gotten to connect with others. It's a great week to just sort of raise awareness. There's a lot going on in the HPN world. So thank you for joining us for our final webinar. Just a few notes. If you've joined us at all this week, you've probably heard this a million times, but today is going to be a little bit different. You won't have to worry about your video as a participant, and you won't have audio unless one of the panelists specifically asks you to come off mute, and we'll make that clear when that's happening. We are going to be utilizing our chat this afternoon for some storytelling and question and answers and things like that. So please do be respectful. We ask that you don't share any medical advice. And please know that any personal health information that you share cannot be protected. This is going to be recorded. So if you would like to share something and have it be anonymized, I'm going to drop our info@oley.org email in the chat. And you're welcome to share your story and information that way. And then we can anonymize your information. This will be recorded. I'm not going to record the housekeeping bit because we have that ad nauseum at this point. So I'll turn it over to Beth and start recording. And then please, as always, nothing in this program should be perceived as medical advice. And just a reminder that the thoughts and opinions shared by the guests and presenters do not represent their respective organizations, the Oley Foundation, its affiliates, or partners. So with that, I will turn it over to the folks who are joining us and Beth Gore to kick it off. Let me stop sharing and start recording. Hold on one moment. Oh, it looks like we are. Perfect. Excellent.
Maisie, so much. So I'm Beth Gore. I'm the CEO of the Oley Foundation, but more importantly today, I'm Manny's mom. So Manny is my son who has been with Essential Line for 13 years this week. So I'm one of the newbies on the panel of people that we represent. So just a couple of really quick high level things I want to talk about as far as why we're having this conversation. So I actually did a survey with Oli about a year ago and was like, what is your levels of stress and what kind of things are you stressed out about? And I'm talking to people as I was devising this survey. I knew that devices would be one of the top ones because that is for me as far as related to devices. And some of the clinical folks actually said, don't even put that on there. And surprise, surprise, drum roll, it came out as number one. So complications related to devices, and that's both enteral and parenteral devices, was our number one stressor above everything else that we could deal with. Tight was number two, is dealing with insurance and payments and all those kind of things, but it was number one. I'm not surprised they were. The second one is Dr. Baskin, who's on the panel today, and I actually did a survey several years ago with Oley when I was the president of Oley, and we were talking about some interesting things, and at the end we had a question 10, which is basically anything else you want to tell us? And in there was the gold of the conversation. And it was the basically, please tell people not to kill me. Please tell them my vascular access matters. Please tell them that, and so forth. And so this is something that he and I worked on for years in the background. There's some guidelines that he and I have helped co-write. We've been down this road of patient safety related to vascular access for a long time. And we just kind of wanted to start bringing you guys into the conversation. Today's conversation one, not the end, not the middle, but the beginning of a conversation we want to have with you. And so the premise is long-term vascular access. It's not the same as that short one. Like my dad had a vascular access that was in for, 5 or so days, never left the hospital. That's a very different case and device and need that I had as his daughter than I do as Manny's mom dealing with the long-term chronic access. So we truly believe that long-term vascular access devices, it's different. And then we really want to hear from you. We want to hear from you today, but I also want to give you a little caution. So throw things in the comments. Please put some comments and stories in the chat, but realize anything that's put there is not protected. It's public. So be very careful what you put there. If you do want to share your stories though, and you want to do it in a private way or a longer version of your story, please send that to us at info@oley.org. Maisie just put it in the chat. So on here, this is full game. Everybody can see it. It's going to be put out everywhere. So just be careful what you put there. But if you do want to share a private personal story that you want to have anonymized, we can do that. Just not on the chat today. So info@oley.org. The first thing that I want to do before I turn it over to Kevin is I want to say, put in there, if you're willing, put in there, how many years have you been with a central access? Like I just said, 13 for us. Put in the chat. How long have you been with vascular access? And then with that, I'm going to turn that over to Dr. Kevin Baskin to kick us off with the conversation today. Thanks for being here, panel.
Well, hi. So I'm dealing with a few technical challenges here connecting to the conference. So I'm half on my phone and half on my computer. So I apologize for any glitches or for looking like I'm staring off into the ether instead of looking at the camera. So what we wanted to accomplish today, I'm an interventional radiologist. Most of my career was spent doing procedures in kids, and much of that was doing central venous access procedures in kids. The same is true for Dr. Rich Tobin, who's also on the panel today. And so, we have lived one part of your experience, that is, placement and maintenance and salvage of central lines and salvage of venous pathways. We certainly haven't lived the rest of your lives, and so we really rely on you to tell us about that. But we have heard you say that you don't feel heard when you're engaging at those moments that are most critical for you and probably most frightening. When you're trying to get access and having a difficult time, when your access isn't working, and when your access is causing you life-threatening problems like infections and so forth. And so we want to improve your sense of self-advocacy. We want to help empower you, to be more effective, not for lack of effort on your part, but probably for lack of effort or understanding on our part, to really listen carefully, to give you credit for having more experience with central access often than we do, and trying to have that conversation where we're providing medical advice, but we're trying to provide it in the context of honoring your values and preferences, and trying not to do you harm. So that's going to be kind of the central theme of this conversation today. And the first part of that conversation, I think maybe Maisie can put up the first part of our poll. Is that possible, Maisie?
Yep, I have them ready to go.
Okay, so if you want to just put them up where folks can see them.
Sure. The first one is, if we feel our concerns are acknowledged and addressed during CVAD-related care.
So I would encourage you all to vote in this poll, either now or later. I'm hoping that it'll be up for a while and that it'll be available to you as participants and to the Oley community in general. And we hope to learn a lot from your responses. Just saying agree or disagree or whatever isn't going to tell us much of the story. So please do feel free to expand on those ideas in whatever you put into the chat or whatever you put into info@oley.org. I probably hacked that link, but it's up in the chat, so you can find the correct one. So how do we help you feel more heard. Maybe Beth can talk a little bit, and if any other participants want to contribute some thoughts about that, tell us kind of the crux of the problem. Where are you not heard? What parts of the conversation aren't happening, and where can we work together as a community to improve the situation?
Yeah, so very, very high level, I would say that it's across the board. And so what I find it a tale of two cities, basically. And you can share that poll results for now too, Maisie. The the tale of two cities is there are doctors who get it and nurses who get it, and immediately they want to partner with me, and you can tell it within a few seconds, almost immediately. And then there's the other ones you like, oh crud, I know who this is. Anybody else that agrees with that can probably understand what I'm saying there. I would actually love to see if Lauren Reimer, if you're willing to come off mute and tell what you just said on there and any part of your story as far as when you felt heard and when you haven't felt heard. If you don't want to do that, you're not required to. But Lauren, would you be willing to share that really quickly as far as when you're heard and when you don't feel heard? What's the difference?
Sure, I'm happy to share a bit. I think there's absolutely, I feel like within the first 5 seconds of talking to a new provider, you do almost know whether or not it's a oh crud or a okay, this is gonna possibly be safe situation. And some of the things that if someone doesn't understand the importance of the material that my line is made of, or why I do not want that 2 lumen line versus a single lumen line, a lot of those factors, if they're not understood within our initial conversation, I'm really concerned to go back in a procedure room and be in a state where I can't fully advocate for myself. So that's kind of where, yeah. Did I
Yeah, I
answer your
agree. And it's almost too late. And Crystal, will you come off mute and say what you just said there? It's too late by the time we're having this conversation. Would you expand on that a little bit?
Yeah. Often, am I off mute?
You are.
Often the conversation is had in a hurried manner while we're in pre-op. Instead of having the conversation before, especially when you know it's going to be happening, instead of having a proper sit down, pre-surgical discussion and going through the questions and having an actual dialogue with you as a clinician, me as a patient, as to where we're going to be placing the line, how we're going to be placing the line, the materials it's made out of. And for me, I am one of the few, or not few, but there are several that have a port, but I'm a port lover and some people are not. And in one instance, what I agreed upon with the nurse and the surgical resident, because the actual IR physician would not come out and discuss things with me, was not what happened in the NIR. And so they're like, no, it's a standard port. And I get back there. Okay. Didn't even think to actually ask and check and verify. But I shouldn't have to when I'm in IR, actually, right, laying there on the table, already scrubbed, as somebody's threading the guide wire through, which I'm fully awake. I'm one of those few patients that just use lidocaine and go for it. I shouldn't have to be asking questions the whole time and confirming that what I want, and what we agreed upon is what is actually happening. It should have already been fully signed off on, and that's what we should be following through on. Does that make sense?
Yeah, absolutely.
Sure.
Go ahead.
Oh, yeah. I mean, it makes total sense. Beth and I were talking a few days ago about the idea of, having a consultation prior to these, major life affecting procedures, about what kind of access you prefer, what size lines you prefer not to have. Oftentimes, I think people who aren't as familiar with treating chronic patients have a, go-to approach, a go-to vein, a go-to line, whatever's on the shelf. And, they may not put all that much thought into your access. I think way too many people treat access as a means to an end rather than an end in itself. And that results in these kind of episodic approaches to care, not individualized. But in thinking through, how would we do that? How would we operationalize that? How would we arrange to have patients come see us in clinic? Where I'm at, I have a clinic. I do see patients. I don't really see central venous access patients in clinic before procedures. It's made me more aware of that as we've had these conversations, but I don't yet know the answer to how to make that happen.
Maisie, will you come off mute and share whatever you wanted to share there? You put in there about the anonymous attendee and then anything that you want to share about this.
Yeah, I think the biggest thing, and I know we'll get to this a little bit later, but I just want to reiterate, I think the biggest thing is the lack of continuity of care from who we communicate with to who does the actual line placement. That's been a huge issue as well. And I think a recurring issue that I've heard, and like I said, we'll touch on later, is the lack of provider who wants to take ownership or support us in the management of our line. So recently I had to have a pick as like an interim line, and I almost couldn't get it removed because they couldn't figure out which provider sent the order for the Hickman placement or the tunneled catheter placement. And so I almost woke up with two lines because I didn't know who to tell them, because I didn't know who ordered the tunneled catheter, which is the same line I've had my whole life. But again, we had to go through the processes. So I think helping us figure out how to ensure that continuity of care and that consistency in communication would be really helpful, as well as who that might be, who we could bring in from our team, who the best people are, because I don't want anybody to feel like they're crossing red tape on our behalf, but that's often the case, and that's not fair to providers and that's not fair to us. So I think you'll see that as a recurring theme as well.
So I see Tiffany's on, and
Yeah.
I don't want to put her, in a.
You're available to speak, Tiffany, and you feel like it, please do. That's what
I
he's
want to
trying to
speak
say.
after, please.
Speak.
So Tiffany, if you're willing,
Yeah.
maybe you can highlight kind of the last few weeks of your life and how this whole issue of communication has affected and is affecting you, right now.
Sure. Can you guys hear me?
Yes, thanks.
Okay. So I know a lot of you who know me know that I have had a long journey with central lines. I'm at the point where they always just call me the girl with no access, and all the doctors that look at my line, all the nurses, like, oh my God, I've never seen that line before. And I'm like, really? Like, that means, first of all, it gives me a lot of hope. Second of all, it's like, okay, we'll move on. So recently I have come to, again, the position where I'm being told over and over again that I'm out of options. I recently, about 3 months ago, actually it was right after the Oley conference ended and we got home, I ended up getting COVID and I got sick. I ended up being admitted. They didn't want to do anything with my line because of the fact that that I have no other spots to go. Unfortunately, so it's been going on I got home, and after 7 days of antibiotics, the symptoms started to come back. I went to the hospital. This time I had the same bacteria, but then I also had COVID, double pneumonia, whatever. At that time, we decided that we would change it over a wire. So the line was changed over a wire. I went home. I was home for about two or so weeks. And this time might be off a little bit, but 2 weeks or so, and I started getting the same symptoms again. After being off the antibiotics. I was heading to the hospital. I had been vomiting for 36 hours. I didn't have, my blood pressure was too low to read. So I was going with my mother. My mother had already gotten in the car. I didn't know that I was as bad as I was. I stepped out of my house and missed the stairs. And I fell and I hurt my leg. And I was at the point where my mother wasn't going to be able to take me. So we moved at the beginning of the year from one city to another. So unfortunately, where I live now is not in the area that we go and get my medical care at. So when the ambulance came, they asked us what hospital we wanted to go to, and I had no clue. So we ended up going just to one of the ones that they said. So we went there, and it was definitely a lot different. But again, they were like, oh, well, we shouldn't use that line. We can't use that because it's not from us, and then blah, blah, blah. And so they were like, oh, we need to stick you and all this, and just going back and forth with them. And so I had been put in for transfer to the other hospital. I spent 9 days at this hospital waiting for the transfer. The transfer had been approved, but I was waiting for a bed. They just kept pushing me off, pushing it off. And then at one point they were like, okay, well, you've been here for quite a while now. We just can't keep you here. So we think that we're just going to put in a, this is when I reached out to you, Dr. Baskin, when they told me that they were just going to put in a bedside femoral line. And that was going to be adequate. I totally denied that. And finally, I was transferred. So I am literally still in, like, I feel like once I got here, I completely restarted the situation, and that should not happen. There should be continuity where every hospital should have the same ways to look at things, the same transfer, the same this, the same that. And I know that the access I have is very limited, and I know that it's very special, but instead of like being so excited or seeing this line, why can't I put more time into, okay, well, if this line is to not work, what can we do next? Like,
Tiffany,
what is there? Yes.
Tiffany, do I remember correctly that you had asked them to sample both your veins and the line when you first came into that hospital?
Yes.
Right, which is the, you know, which is how the guidelines read, you know, from the Infectious Disease Society of America. And did they understand what you were asking, or did they just do what they wanted to?
You were shocked I told you this. No, they had no idea with bloodlines, and I was at a hospital that was not a little hospital, definitely a hospital that you know of how to draw a blood sample. I believe I had one. I may have had 2 different days where they did them, blood cultures, but they did not do them when I came into the hospital. They finally did do them. I believe they did one off of the central line, but I don't believe they did anything else. And then at one other point, they did one peripherally. And that's when they, you know, said that one had been growing. But we didn't know what was growing because we, you know, so when I get to the hospital, and I was growing fungus there. But when I got to the new hospital, I started growing bacteria. But we didn't know when that was like done because they weren't doing them consistently. They weren't doing them for a certain amount of time. I then get here and they're like, oh, it has to be 48 hours when they're after the fact that things are growing. And they say 48 hours after that last culture that was growing positive. Once I started growing negative, they could put a line in back in, but I never did. So then finally they did put back in, and now I'm still at the same hospital because at this point we are back to the exact same point that we started with 3 months ago, or at the exact same spot we were at, because now we're back to what do we do? You have no access left. Now you're still testing positive. You keep having fevers. Can we send you home or not? Because but just the cultures just keep growing and growing and growing. So now it's a point where okay, they're saying, well, if it's still growing, we need to take this line back out because this line was changed over a wire here at this hospital. It was back 10 days ago. I had this change over a wire, and I'm still in the exact same position that I was in at the beginning.
So Tiffany, thanks so much for telling your story. I know there's an awful lot more to the story, but I think the point that you make so eloquently is you depend for your life on this line. At the same time, your life is threatened by things that happen with your line, like these infections, and oftentimes what the right thing is to do, and you ask them to do that for you, and they just have their own ideas, which aren't according to standards. And no matter how you ask, people don't respect the relationship that you should be able to have with them in partnership in your care. I know Rich Tobin had something he wanted to say.
Yeah, I just wanted to comment on the multiple threads, because it's and Deb Willis sort of brilliantly predicted this and brought this up in terms of legislation and standard maintenance and things of that nature. So number one, informed consent is a standard. And the one of the discussions was clearly substandard in terms of informed consent, because the person in charge needs to get informed consent, not just give you something to sign. That is not by definition informed consent. So just to know your rights and say, look, I need, and especially in long-term venous access, it's a very complicated thing. So making these choices, you need the proceduralist or who's going to make the decisions to be aware, and they may or may not have the ability to read the chart and get a feeling of the complexity. So informed consent, and so from Deb's point of view of things we can do to make more standards and make laws, that's one of them. The other comment was, who is the physician of record? And Maisie was talking about that in her discussion, and that is a global problem, because there is no physician of record really for venous access, and especially long-term venous access, because they're not actively following. So what Beth said at the beginning about differences between long-term and short-term venous access in hospital, out of hospital, these are especially challenging problems. And so do you need, as a patient, for you to know who is your physician of record, so you can tell them? Because you'd almost have to carry that in your pocket when you get in. And then I still think there would be problems getting a hold of these people. But you have to, and Oley and all of us together need to sort of craft something that could help patients, give them a passport, if you will, with this information on it. And by the way, as the patient, you have control. You could decide. So, because again, you're the one giving informed consent, you're the one that directs your care in some way.
You say that, Rich, but that's not true. I'm sorry. I'm gonna
really?
call
Okay.
BS on that. Sorry. And I'm
Okay,
not
tell
saying
me.
you're wrong. I'm saying it doesn't happen. Like,
Well, that's what I want to know. That was the impression that I had. So you have no control?
no, absolutely not. So I'll just give you, and I know Julia, you have your hand up and I'll come to you, but I'm just going to give you one, or actually two really, really, really quick stories. So Manny needed an endoscopy procedure and they had this informed consent and I did this and it was something that was going to last for 45 minutes. It's not going to, they didn't leave something in his body and it was going to be over. And there were 3 levels of things. And I just said, hey, I'll sign for all 3 right now because I know Manny and he's going to escalate up. I just know him. And they said, no, we're only going to get consent for this 1 level. After that failed, they said, hey, we need to come back out for the level 2 of it. And because it's changed. And I said, again, can you do number, just that. And then they said no. And of course, it ended up being number 3. That was for a procedure that lasted an hour and had no long-lasting implications for it. By comparison, Manny went in for a procedure that was going to be a test. They said, we're going to use his central line, which at the time it happened to be a Broviac. I said, phew, what are you going to do? So imagine my horror when an hour later he comes out and he's got 9 sticks, 9 hematomas, and they're still using his central line. Or the time because we thought we'll just throw in an IV while we're in there. I did not give consent for that. I did not give authorization for that. They said, yes, you did. It was in the informed consent at the beginning of to be treated for the hospital. Okay, so maybe that's just an IV. Maybe that's a different thing. One more is I got to the surgeon. He went in, we were going to come out with a 4-2 or a 6-6. That's what we had agreed to. They deviated from that plan and he came out with a 9-6 as a 10-year-old and this thing was as big as a dialysis catheter for him and it was way too big. I did not give consent for that. I did not give authorization for that. What I agreed to was that I would have a procedure done. This is what we talked about. And so I felt very betrayed. I know that was a question in the poll later, but I'm telling you, we are not heard. We are not heard. They will pat us on the head, say yes, 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 and then go do whatever the blank they want. And sorry that I'm getting grumpy, but Julia, your turn. I'll be quiet.
No, I never want to tell you to be quiet. I think all of those comments are really right on the nose. And I would say, just yesterday, I had to do an online training for what informed consent is. And it was striking that what the online training says informed consent is and what people do for informed consent is vastly different in reality, right? It's just people are not achieving that benchmark at all. And so it sort of links to my follow-up question, which is not a full question I don't think that we have, but sort of one of the things that I encourage my patients to do, and I both work as a hospitalist in internal medicine and as a primary care physician for underserved populations in community health centers, is to encourage them to try and speak to the patient advocate. I think it's obvious that patient advocates don't have the knowledge or training to support patients with central venous access. So I'll just throw that out there as sort of a baseline. But what are the experiences of our patients and our caregivers with trying to work within what's supposed to be sort of the fail-safe system for healthcare, where the patient advocate can address mismatch between how the care team is responding to patients' needs and requirements and the way that care is being executed? Because I think, from this conversation, it's very obvious that we need sort of a central venous access specified Bill of Rights and standard of care that we can hold people accountable to. But I'm curious to know if people have utilized the patient advocate to say, like, I need these kinds of cultures, they're not being drawn. I didn't consent to this kind of catheter, but it was put in, those kinds of questions and answers.
Right, Julie. I think that that you're spot on. That there does need to be some explicit kind of standards of care or preferences that patients can express. We don't really have that, available to us on either side. And I think patients feel very ill at ease trying to tell their clinicians what to do, because at the end of the day, the clinician is the one with the sharp object, right? And so you don't want to bite the hand that sticks you, I suppose. At the same time, you need to have the freedom to advocate for yourself for those things that you feel are important, and to have the discussion about, what's meaningful to you, what was, consistent with your values and preferences. One aspect of this whole conversation is that you know, Beth and I have spoken about in the past, and I know others of you have spoken about, is that what standard of care for the bulk of patients with central access may not be wise or safe for those of you who rely on chronic access. You know, for example, what do you do when a line doesn't work? For the bulk of patients, pulling the line would be, you know, an adequate response. But for you guys, pulling the line may be loss of a pathway or several pathways, and you only have so many, and you need to hang on to them for as long as you can. So how do we differentiate you as a group from everybody else? And this is a really difficult topic for us because we can't identify you easily in the medical records. We can't identify statistics about you, you know, where they exist. And so finding a way to identify you as members of a population, of a community, in order that we can understand how the healthcare system affects you and, you know, how we should be thinking about you would be really helpful. I know that both Julia and Jeff Dunkel have some ideas about how we might, you know, think through finding a way to label you as part of this group so that you can be identified with special needs and considerations. So maybe Julia, could you talk a little bit about that? And then Jeff, you can follow up as well.
Yeah, absolutely. So I think the conversation is leading me to think this, you know, the care plan and the requirements and the preferences, you know, those all can be captured for end of life care and advanced directives. And I actually don't think that chronic central venous access care is anything other than advanced directive. It's not necessarily about whether or not you want to be resuscitated, but it should be a legal document that the care team has to be held to that standard. And I wonder if there's not a way for us to create an advanced directive around venous access that goes in the same place in the chart, and there's the same level of expectation that the care team has to conform to it because it's a legal document and standard. And I would think that, you know, I saw the comments about patient advocates who sort of seem to be just, you know, covering the hospital's butt or don't even exist. And I think the big thing that gives physicians here on the side. So could utilize the leverage of compliance and this kind of care, it may be a bigger lever than just something like a care plan. And you know, this also reminds me of you know, conversations around birth plans, right? Because in the medical community, there are people who encourage people to express their preferences and to think about a birth plan, but there's also a lot of frank dismissal and sort of disregard for the patient's you know, attempt to put their own wishes sort of into a care plan. So I think the advanced directive pathway might be a more effective pathway for sort of generating, let's say, responsiveness to patient preferences.
Thanks. So what about coding to identify patients in this population?
And if I can jump back in, yeah. So this is a perfect example of something that in healthcare is currently only able to be described by people who sort of know it when they see it, right? So we can't utilize big data to identify patients who have, you know, the special circumstances or critical needs from the patients who, to Kevin's point, are just getting a central line after a car accident or, you know, for a surgical procedure or something like that. So I think that it is possible for us to sort of generate on multiple terminologies a set of codes that both helps clinicians to sort of have the time and compensation to take extra care and to do more careful procedures and more counseling with patients who have these kinds of needs, but also to help us identify this subset of patients who get venous access and treat them as a separate population, which is really critical for us understanding sort of both the outcomes and then also, you know, how we should apply differently care standards. If the system can't differentiate the two groups of people, it's going to have a hard time implementing infrastructure to do different kinds of surveillance, different kinds of documentation, different kinds of ways.
So Jeff, you were talking to me the other day about the potential to alter coding or update coding for the more complex issues that need to be addressed in this group, so that, just like Julie was saying, so that more resources can be put on task, and the payment that is needed to help clinicians to put more resources where they're needed can be achieved.
Yeah. So first, just a lot of sympathy for everybody on this group. Reading the comments, there's a lot here. It's a lot to unpack, and I think your biggest challenge is you've got unlike kind of the standard for medicine, where we can look at a code and understand a disease state. Chronic conditions where you need a port, right? It spans across, and it makes it very difficult and challenging to, as Julia just said, to appropriately identify who's at risk, who can we pull a port, who can we not, and so that creates this challenge, which obviously creates groups like you all. I think my experience in attempting to bring a lot of technology into the medical space in the United States, and being successful sometimes and failing other times, what I've learned over my career is, first, you have to have a clinical benefit. Second, you need a fiscal incentive, or at a minimum, not having a fiscal disincentive. And then third is you have to fit within the care pathway model, meaning you need to not be overly burdensome. So right now we have two strikes against us within this group, right? Just through the nature of what gets adopted easily and what doesn't. And so the first thing I think that makes a lot of sense is how do we simplify the information of transfer, right? That's the first thing, and that's probably not a Jeff Dunkel question. It's probably like a Debbie question, who has portals for patients and EHRs that she stood up. But the first piece is in DC in particular, when you're trying to force change, going to someone with a problem is going to get you heard. Going to someone with a solution is going to get you traction. And so going in and explaining the problem is going to have individuals that are not educated in the topic trying to make decisions that will oftentimes not lead to the results and the outcomes that you want. So bravo, Kevin and team, for trying to come up with a solution. I think that's number one. Number two is getting the patient advocacy behind it. And Julia mentioned it in the hospital, to make sure that your voices are being heard, and it's being heard, not just you going in and kind of being, thanks for your opinion, doctor. Here's what Dr. Google said, right? but also going in and saying, here's my history and here's my contacts and here's why I'm kind of pushing back. But I do think at the bigger picture, if you really want to change things, what you need is some form of a modifier on an ICD-10 code or a CPT code or a HCPCS code that allows for patient review specific to venous access and history of venous access to be a reimbursable component. And to what Dr. Tobin said earlier, I think that also comes with standards of care and Bill of Rights. So I'm just trying to kind of I'm assimilating basically the words that everyone else has said and trying to parrot them back. But the thing that is needed here is organization, because of the breadth of the diseases that are covered and the lack of continuity that makes it very easy to go in and give a quick fix.
Thank you. I know Macy has your hand up. Would you go say whatever you want to say, and then I actually want to say something too.
Yeah, I just want to note, you keep mentioning the patient advocacy efforts, and there are dozens of patient advocacy organizations, Oley included. And like I said in the chat, we've been having these conversations for decades, and it's just a matter of what providers want to be included in them. And what happens is that we often reach the providers who already get it. And so I think the way that you all can help us as providers is bringing in the people who don't want to hear from us because we're just patients. And they have to view us in a certain light, and that's totally fine. But if you look for patient stories, they're out there. We have dozens of videos just through Oley, let alone the other, handful of organizations that focus solely on the patient perspective. So I just want to make sure that we're not putting the onus on the patients to make changes that we are literally incapable of making, because if we were capable of making them, they'd already be made. So I think there needs to happen something on a systemic level, like the codes that you all are talking about. And the other thing about standards of care is that the standards of care vary greatly from provider to provider. So there also needs to be some internal accountability from institution to institution to actually uphold those standards of care, because we're tired. We're really, really tired and we're sick, and we can only advocate for ourselves so much. So we need you all. And I'm so glad you're here, and I'm so glad you're listening and we're having this conversation, but we are tired and we need providers to be our voices, because we don't even see the same provider, from one visit to another. So we need to ensure that there's some consistency happening on an institutional and systemic level, so that we don't, roll our eyes because we got the doctor who sees us as a burden because we know the difference between a port and a tunneled catheter and they don't. We need doctors who will see us as collaborators and not competition when we are on a level playing field in terms of our knowledge, because we've been in our bodies longer than they've been out of med school. So I think that's really how you all can help us as providers, is just helping amplify our voices, because we've been doing this for literal decades and we are exhausted. So thank you.
I would give a standing ovation if I could, Maisie, right now, and you can see it in the chat as well said. I think you can hear, those of you who are here to listen, we feel like we fuss at the choir, and that is not what we're trying to do. The choir listens to us and you guys get it, and you would change it in a heartbeat if you could. That's not the problem. You guys aren't the problem. The ones who listen to us, you guys are not the problem. And so what we are saying, though, is we're still not getting heard by the other side. We're not. And no matter what we've done, we've tried. So we need new tactics. And I truly believe that something like the ICD-10 code or whatever it is that says, hey, let's identify this patient at the beginning. Now, like a Manny who's already been in for 5 years, maybe we can retroactively add that code to his chart, but to go backwards and say, this is a different and unique patient. They have different and unique needs, and therefore we're going to go down this different pathway. What we're saying is, I'm sorry that we're more complicated and more expensive, but we could get less complicated and probably less expensive if we were collaborated with from the very beginning and treated in a unique way, would probably ultimately save everybody some headaches and challenges along the way. I know Deb's had her hand up for a second, and then Julia.
Hi. It's just every time I talk to Kevin and I just hear these, it just really touches my heart with the sadness and the frustration that everybody goes through. I want to share something that we've done recently in hopes that maybe this might be a path to get at least something done. So my company has been working with the ONC, and that's the government entity that mandates technology in the United States, and bringing to light some things that we see that are wrong, that are, that are hindering patients from getting their data. And so several of us app developers got together to basically tell the story to the government, because sometimes they just don't know. It's not that they don't care, they don't know, and they really don't know what to do. They need our advice on what to do. And so we came up with a really nice document that identified every problem that we see, and then we told a little story about it, and then we said, this is what we think you can do. And it was in we broke every problem and solution into multiple categories, and one of the categories was simply to improve the rules. So in this particular thing, if we apply it to the problem that we're seeing now, we can say improve the rules and to identify really what does true informed consent mean. You can't just say it's a signature at the beginning when you sign in that lets them do anything they want to do. That's not really informed consent, because you're not being informed totally of what possibly may happen, and you're not consenting to everything that they might do to you. So that's one category. The second was where we're asking the government to really investigate and enforce where there is already an existing rule, but they're simply just ignoring it because they don't want to deal with it. And the third category was really to engage or educate the health system about the rules, because sometimes it's really, they do care, but they just don't know. And the fourth category was really for the government to use their platform to really express how important this is, that they needed to start shouting it out. And so we gave this to the government. We had a meeting, several of us app developers, and I was so impressed that a blog came out. I don't know, I think it was last week, maybe, all my days blur together, where they said, we heard that all these things are happening, and they put in red, we are going to start really coming down on you. And so what I'm saying is that us coming together after years of frustration of seeing barriers to patients getting their data, we came together, we said, these are the issues. We had a little paragraph of how important it was, and then suggestions to the government. So, you know, I don't know if that's something that would help this group to really get at least one thing checked off the list, you know, informed consent, what is it really? And what happens when you don't comply? Are there, because there's $1 million fine for the ONC has for data blocking. So maybe sometimes saying, well, this is the fine if you don't do what the patient said. So anyway, I feel that having the government behind us to make sure patients really are listened to, and that there is a stick if they don't, because I think that's really what propels a lot of change in systems. And that's all I wanted to say.
Julia?
Yeah, and I do want to applaud Debbie and her team's use, a leverage of the patient access rules for data. I just want to call those out to people, because there are a lot of requirements around your own access to your own data and your ability to share that information. So I encourage people to invoke those requirements if they're struggling on the data exchange side. In regards to informed consent, though, I think two of the major stakeholders, I haven't heard mentioned explicitly, are the Office of Civil Rights at Health and Human Services, who I think should be the owner of compliance issues around truly informed consent and adjudicating patient reports of noncompliance to informed consent, and the Joint Commission, who regulates and accredits hospital systems and hospitals in the United States. I think on the Joint Commission side, we could both sort of push for standards of care that could be included in accreditation rules and requirements around venous access and venous monitoring, certainly. But also, informed consent, I think, touches both the Joint Commission and OCR's sort of regulatory authority. And I think that those are probably both organizations that would be open to having some of these conversations, in the sense that, you know, there are providers who genuinely care about this. Definitely some of them who genuinely care are underinformed. And I think it is important for us to continue education and outreach to clinical organizations. There is also a large group of people who won't be paying attention enough, won't encounter this problem frequently enough, or maybe have a paternalistic attitude towards healthcare and procedural based medicine, that they would be less inclined to attend to that. That requires us to also have regulatory backing behind this. And I think that's why sort of, again, I point back to, you know, is there a legal document that's enforceable, like an advance directive? And is there a standard, either on the informed consent side or on the standard of care side, that can be used to sort of say, you know, your hospital administration is going to be held to this standard. They're going to be responsible for enforcing you to this standard. And that is an existing mechanism in healthcare, which, you know, can be relatively easily leveraged. But I would encourage us to engage the Joint Commission or TJC and OCR on these topics, because I think that they would be interested in thinking about how can, in the digital era, we have better insight and better enforcement of these requirements, which, as I pointed out, you know, we do all of this training and people click through all of the boxes in the training, but they're not executing that in practice. And I think from a digital perspective, we can also use data to help hold people accountable to their actual implementation of true informed consent versus checking the box. I can say I went to a doctor's office appointment recently where they said, so you're going to sign this document, which is a notice of your privacy rights, but they didn't show me the document. She said, just sign it. It's on my screen. And she asked me to sign 3 documents that I could not even visualize. And that was a standard of practice. So I know how bad it is. It's really, really bad, but we need to work with the organization to have the power to enforce these kinds of new standards across healthcare.
I agree, and I see Rich's hand up, and I'll call on him next. But just so you guys know that Oley recently became a member of NQF, National Quality Forum. They're the ones that write the measures that go to the Joint Commission. And so they've actually asked if Oley would put on a webinar in the near future, and I agreed to that. It's not about central lines specifically, it's about nutrition support. But really it's the idea, what you're saying there, for those who may or may not understand the Joint Commission's role. I went down a rabbit hole to say, whose job is it for patient education and whose job is it to safely discharge patients? So whether that's with the central line, parenteral nutrition, enteral nutrition, going home, whether it's the first time or the 14th time going home, it's actually the Joint Commissions, which is why I went down that rabbit hole. And so working collaboratively with them to say, if patient education is not happening and it's not doing well, then this is the patient education that we feel needs to happen before a patient goes home with any of those 3 things. And I'm including long-term central access with or without parenteral nutrition in that. So if anybody wants to help me, info@oley.org. Rich?
Thank you. It's just some comments. So, and I agree with the very well stated issues and ways we could get together and work for government assistance in getting these things across at the country level. However, the feds are somewhat uncertain. They don't often have the necessary knowledge. And for example, they have in their wisdom decided that bloodstream infections from central lines are never events, and a never event means that you forfeit payment as a physician and a hospital. So the result of that is at the hospital level and the doctor levels, it's obfuscated. So the reason and I've been reading the comments in the chat, part of the reason that people are noticing that they're not getting the support from hospitals is because they're never events. And it's publicly reported as well as financially disincentivized. So there are selective in our world of venous access. It is a big issue, although it's patchy the way the federal government goes. And I'm not making wide statements. I'm just telling you about this one quirky one, and it's proven that disincentivizing is not the way to go, and that has to be changed eventually.
For sure.
So there are standards for informed consent. Just as a statement, and we could adopt them and get behind them or modify them. And of course, we would help do that. The other thing that is a problem, even though there are many, many standards and good ones on central venous access and peripheral access and so on, you, Beth, and others have focused on this, and I just wanted to make a point how important it is to stratify those and identify the long-term venous access patients, which venous access is probably the single biggest procedure performed in the United States with many millions, okay? But people who have long-term venous access needs, these standards don't really support them. And there's about 10-12% of the total number of patients requiring venous access that are long-term venous access patients from a wide variety of reasons. Okay, so there needs to be a standard for them because they are unique. They're unique in the resources that are required, the knowledge that's required, and it would help there are many, many wonderful comments that are expressing frustration and lack of knowledge, lack of skill sets. But if you don't make the standard, they may be at standard for the majority of venous access patients, which are short term, but they're not for the long term. So we need to focus on that subgroup specifically and make educational materials and get rules and all that stuff set up. Let me see if there's one other thing I could tell you.
While he looks, that's the answers on the screen right now is basically the question, do you think what helps everybody else actually could potentially harm us? And most people said yes. Back to you, Rich.
No, I think I'll yield. Thank you.
So I think that we've hit a really critical point here, which is it's very difficult to leverage change in the system when we can't provide the data that suggests what the improvements of care would yield, how many injuries that are currently occurring would be prevented, how many dollars that are spent on high-end, high-risk care because things have gone too far, how many of those could be prevented, how many dollars could be saved. And so without that data, it's very difficult to get anybody to move anywhere. And I've tried, on so many different levels, with the payers, with the institutions, with the FDA, with the, ARC, which is the Agency for Health Quality and Research. So many areas, and I keep getting the same answer, which is, well, show us the data and maybe we can help. The fact is we don't have the data, and more even than that, the current system for surveillance for CLABSI, for central line associated bloodstream infections, penalizes people who report honestly. And so it's one of those unanticipated outcomes of policy decisions. They wanted to reduce the frequency of catheter-related bloodstream infections. And so they said, well, we'll just penalize hospitals when they have them. Well, for one thing, it's not totally under the hospital's control. People are going to get infections no matter how good the care is. People are going to get a lot more infections when the care isn't as good. But hospitals don't always control whether people get infections. But if they don't report them accurately, which they don't, then how do we keep track of what we did to make it better, or what we did to prevent it, or what we did to make it worse? So the agency that looks over this problem, that is responsible for national surveillance, is the National Healthcare Safety Network of the CDC. They don't have the resources to do a better job, frankly. Every time Ebola and COVID and whatever else comes along, it sucks up their attention. And so maybe they would like to help, but they just can't. CMS, Centers for Medicaid and Medicare Services, who pay for a lot of care, won't do anything until they see a return on their investment. but we can't show the return on investment if we don't have the data. So one pathway that we've been thinking about is to get patients more involved in contributing their data. And I know on some of the web conversations that we've had recently, you as patients have expressed a willingness to donate your data for studies, but you don't know how. I think one person mentioned that if you're enrolled in an IRB approved study already, that you can contribute your data. But how many of you are enrolled in IRB approved studies? Probably very few. So I'm going to ask Deb Willis to just describe an innovative new way that patients can be involved with pretty minimal effort, but pretty maximal potential to help us gather the data that we need to push people for change. So Debbie, if you could talk about your project.
Absolutely. Would it be okay if I showed something on the screen? I think if we
Sure.
share, it might help. Okay, let me see. Oh, sorry, that's the wrong one. This was actually what I was talking about earlier about sharing stuff. Let me stop that. Sorry. And I can send that to you, Kevin, later about how we were successful in getting change with the government. Okay, can you see my screen?
Yes, thank you.
Okay, so what this is shows how a patient can gather their data and share their data. So we have a consumer application called MyLinks. It's free. We don't charge anything for it. We built it out of our own pocket. Simply, I have a family that has a lot of cancer, a lot of Alzheimer's. I'm a cancer survivor. And so this was my mission to empower patients. So patients who want to join a study can download their data from all their EHRs. It uses the FHIR API. And they have their own, basically, you have your own mini electronic medical record that's just you. And so with that, if you want to join a study, then we would engage with you to sign you up. And let's say here on the lower right is a registry. That data can be sent to public health, like we're working with the FDA for you to do adverse events, like if something happens with a medication. I'm also talking to them about foods, and we want to broaden what you are able to share quickly with the correct government entity if something happens to you. So we empower you to gather your data. You don't have to share it with anybody. It is yours. But if you decide you want to share that data for research to, to improve your clinical care or the care for others, this is what we're doing. And we're standing on your right for your data. And I figured I'd show a picture. I don't say it very well, but it really is a way for you to gather your data in MyLinks and share your data with whomever. Now, if you want to join research, if you want to share your data with a registry, then we need to engage with the person who's sponsoring that so we can get you in there, signing a consent of exactly what you want to share, how long you want to share it, who you want to share it with, and you can take consent away at any time. We make it very easy. It's your data. You do whatever you want with it. So I'm going to leave this here for a second in case anybody has questions.
So thank you so much, Debbie. And so one potential way to use this is to construct a study where patients basically enroll themselves. You're the community at risk here. You know who you are. And so if we can find a way, and I don't have that way yet, but if we can find a way to construct a study that allows you to enroll in the study wherever you get your care. Oftentimes studies are done through the institution, but an institution isn't going to reach out to very many of you. You're in, places all over the country, right? Little hospitals, big hospitals. And so I'd like to create a pathway so that you can contribute your data to this study so that we can get, a representative understanding of what you're going through. It will help us. I see Jessica talking about CLABSI rates in the chat that are really, a horrible measure, very inadequate to the task at base, and then even worse because people are not telling the truth, about what's happening in the hospital to avoid penalties and public exposure. So it gives you a chance potentially to be involved, but it also gives us a chance to interact with you if you're willing, so that as you're going through your experience, you can share the bumps along the way, the good things along the way that we could never get through a conventional study. Julia, you were talking about some potential pathways to do studies like this, like Odyssey and like CRISP, and then like ARPA-H. So if you could just touch really briefly on what those look like and how we might, bring them to us to make use of to improve our understanding of the problem.
Yeah, so I think that, this area calls for multiple kinds and levels of data. And so I had mentioned Odyssey to Kevin, which is an international open data research consortium, where the idea is to have the individual health data warehouses create a mapping, which is like a translation of their local data to a shared data model or description. And then for them to ask a question, a standardized question at each institution, and then have each institution contribute those results. So that would be a method of getting information from healthcare organizations about things like CLABSI rates, procedure frequency, the comorbidities of the patients receiving these kinds of procedures, even potentially outcomes like complications and death. I think also, though, we need to do some more prospective kind of approaches. And I think that's where sort of patient consent and enrollment into studies that happen sort of across the health ecosystem is really valuable. So as Debbie described, you could opt in to a study and contribute your data to that. And one of the nice advantages of that approach is that it pulls information from wherever it can get it. So many patients need to go to multiple institutions for various reasons for care, and that pulls all of that together in a single patient identified record so that the research can look at sort of that longitudinal approach at a single patient. And then in regards to sort of the ARPA-H and sort of technology, innovation, AI opportunities, any place that we have big data, we could potentially apply machine learning and predictive analytics. That would include sort of the Odyssey kind of model, although that's a little harder because that data tends to be already somewhat pre-aggregated or normalized. So some of the nuance of the data will get pulled out in that process. But also our use of, technology that helps us to document and validate the data that exists in clinical records. So, oftentimes patients are only seen when they have a hospital or healthcare-based physical encounter. And so all of the data about what happens to patients in between that time is generally not captured. And so utilizing sort of a patient-facing solution like My Patient Link, or even a way that a patient could sort of represent their own procedure history or their own symptom history, and incorporate that into a standardized record. And that also allows us to capture things like patient experience. Each one of those aspects sort of adds richness to the story that we're trying to tell to help people to understand the problems that we're facing in this area, and potentially that'll also allow us to see if we implement solutions, are those solutions actually moving the needle, or are they not implemented correctly? Are they not the right answer?
So
Thank you for sharing. Can I just ask a really quick question, or I'm going to ask a really quick question, Kevin, is I don't know if you saw the poll results that said nobody said no. Some people said yes immediately and others said, tell me more. So in a very patient friendly, high level, 30-second kind of idea, would you share what would that entail for us to say, yes, I would share my data? And then secondly, in the comments over here is, how do we address when so much of the data is actually wrong?
yeah, I noticed that. So a couple things. You all have the right to your data by law. Nobody can prevent you from getting access to your data. And if they do, as Debbie mentioned, there are enormous fines for blocking you from getting your data that most people don't know about. And we can probably get you more information about that to post on the website. In the process that Debbie described of gathering your own data together from all the places where your electronic health records exist, you can do that API she was talking about. That's the way that, you know, two computers talk to each other. And so it provides a pathway from your EHR to you, to a protected, you know, file that could live in the cloud, where you could gather your data together, and you can gather data points from one aspect of your care or from all aspects. You control it, and you control what happens to it. It could go nowhere. It could just be for you to refer to. You could share it with a consultant. You could share this data point, but not that one. You could share it for 24 hours or the rest of your life. It's your data. You can share it any way you want to, and nobody can make you do anything different than you want to. I don't know how to get data corrected in the electronic health record. So that's something that we would have to explore and get more information for you about. I certainly recognize that it's a problem. It's a huge and universal problem. So it's your data. You can do with it as you please. If you choose to share it, you can do it in a protected way. These things aren't all well worked out yet, because these options haven't been around for all that long. We don't have we have IRBs, institutional review boards, if people are doing research in an institution, to provide overview of the scientific method and of the protection of the patient's rights who participate. In a situation where patients donate their own data, we don't have well-defined parameters around that to assure protection. It is a protected process, but you know, what they can do with it, who can use it, what the person who uses it can use it for, those things aren't all perfectly well-defined yet. And so we need to get more information about that. So I'm sorry, is that mostly answering your question?
Yes, thank you.
Good.
And Kevin, I can add to that. So when I mentioned data validation, what I meant is to help us understand what information that may get into the record is true and what information may just noise or even incorrect.
Right, and that's exactly what I don't know how to do. But one thing I just wanted to.
So there is a process in clinical care called reconciliation, right, where people go through medication lists and problem lists. One thing that's good about APIs is that they're bidirectional. So you should have the opportunity, if you have a data warehouse accessible through an API that's pulling information, also to send information back to correct that. Now, how good organizations are in responding to those messages and requests for correction is variable. And oftentimes correction in a local record requires like a administrative process in which you ask a human person to go in and basically confirm that that old information should be written over. I think this is an emerging area in sort of health IT standards to say, how do we show which information we can prove is right, and how do we have information that may or may not be right? Specifically to say this information looks like it could be bad and we should ignore it. And how do we sort of stamp with approval things that the patient says, yes, that's true, that multiple providers say, yes, that's true, so we know which information to trust. In regards to data sharing agreements, anytime you consent to share information, you do have to, there will be a series of statements about who's having the information and what's going to happen to it. But in reality, those agreements are difficult to negotiate and understand the terms of. And so part of, what you have to deal with is how much do you trust the organization to be a good steward of your data who's going to hold it. And sometimes you have relatively little control in a situation where you have to say, yes, in order to access or manipulate my data, I have to agree to terms that I don't like. I encourage people to, take a look at those or reach out to Office of Civil Rights or ONC if they have concerns about data sharing agreements. I'm sure Debbie can speak to how my patient link treats data, but I think the expectation is reasonable that organizations not sell your data or share it with third parties without your consent. And those are things you can look for in a data sharing agreement.
Julia, so, how do you deal with the intense amplification in the electronic medical record of all false and true statements? Because generally speaking, every clinician that does rounds every day cuts and pastes what was there before and then adds one thing. So if you say whatever, so if you make a mistake on the first couple of posts of information, it'll last for a lifetime for that patient, and ridding the record of these many not citations, but notes or copies of these notes are, if you read, as you do, when we read and when I read medical records, they're very messy.
I mean, the goal of reconciliation and validation processes is to try and tamp down or eliminate bad noise and to sort of validate and gold stamp the good things. As I said, if there's really something that potentially can cause harm to you that's incorrect in the record, right now you probably need to reach out to an administrative body to say this information needs to be redacted because it's wrong. Over time, though, I anticipate, increasing use of AI should right now be on data quality problems. Quality of data in healthcare is very low, actually. And many organizations don't enforce or act on the required actions of validating and questioning whether or not the information they're getting about a patient is true or not. But by getting access to your data, you have the opportunity to challenge the veracity of information that may be in the record. And by participating in data gathering activities where you can say yes or no, this is true about me, that's another opportunity for you to add data that can overwrite the bad data or flag it as information that may not be correct.
So I'm hearing you guys say that data isn't always perfect, but it's the best we've got, and we still need your data. That's really how I need to wrap that up. We have about 5 minutes left. I'm going to turn this back over to Kevin here to wrap up. And at the very end, I'll give one plug for a document they created that may help with some of this stuff. Kevin?
Yes, thanks. So, before we end, one question I wanted to put to Jeff Dunkel is, these are enormous issues. They're system-wide. We see agencies that are perpetuating bad behaviors, one of them being CDC through the National Health Safety Network, and CLABSI surveillance that has such an impact on everything that's done about central access. We need change at a fundamental level. And so, where are the levers on a national basis in Congress, in Health and Human Services, that we can take aim at? And do you have just a brief, set of guidelines you could give us either now or later, as to, how to go about affecting real change with teeth and with funding?
Yeah, man, that is a loaded question. Not one for 5 minutes, but I'll do my best. So historically, if you're kind of starting from scratch, and I don't know that that's the case here, but in the event that you were starting from scratch, you would work through two different committees in Congress. One is Energy and Commerce, which has responsibility for healthcare, and Ways and Means, which is responsibility for funding of initiatives. Those two come together and they agree, and you pass a bill through Congress on those two fronts. And then your next step is in the Senate, which is the Senate Health Committee, Health, Education, Labor, and Pension, which is predominantly health. And those three kind of, when you're pushing a bill through, that's your path. Now, the big asterisk there is it's entirely possible that's not necessary. There are other paths, and depending on what your argument is, right, you can use the Office of Management and Budget at the White House as an example. If your argument is that there's that we're fiscally punitive towards the taxpayers by not acknowledging that this exists and it creates more of a burden. I don't know that one follows here. So I think the correct path is the one that are being mentioned earlier. What I sense on this phone call is that people are frustrated because it takes too long to go down these paths. That's a different problem, but I do think it is the right solution to work through these groups like ONC. I did like the idea of kind of JACO or some of the kind of more laboratory specific groups associated with infection. I think that it was mentioned earlier that there are penalties associated with infection that are never events, and because of that, you're never going to see a report. Never report a never event, so to speak. Kevin, I don't know that I'm answering your question. I guess what I'm saying is there's a lot of routes.
Yeah.
And I think what I will repeat earlier is if you go with a problem, you're going to wind up being an amplifier and being a voice. If you go with a solution, you're going to wind up with a chance to push it through. And so I would just strongly encourage, I like what Deb has done. I like the work you've done on Vanguard. I would strongly encourage coming up with a fix, a solution. It doesn't have to be perfect, but something to get started that people like myself, who are very empathetic to what's happening, but I don't really know exactly what I can do. If you give me a solution, now I can advocate behind it.
Thank you so much. So, we've touched on a lot of topics, but the main message that I hope we are sending is that we're listening and that we want to hear you. This is the beginning or a continuation of a dialogue, but that we want to really engage in more deeply with you as partners. I'm hoping that we're going to be able to set up more of these kind of webinar sessions where we can interact with you as patients to get information from you to guide us how to improve your world. And I'm trying to find a way to bring together more experts who really do this day in, day out, who can answer the question when people say, oh, well, you have no pathways left. I mean, it breaks my heart every time I hear somebody say that because I don't believe it's true. But we need to find you guys resources that can get access when nobody else can find a pathway, and that can offer solutions when there are persistent infections and so forth. And so, we can't provide healthcare, directly to each and every one of you, but what we can do is look at the scope of the problems and try to offer some expert advice. And so I know it's 2:30 and we're stopping, so I'll turn it back over to you, Beth. Thank you.
Thank you. So, first of all, is there a list of people that know what they're doing anywhere? And if it does exist, can I have it? And if it doesn't exist, can we create it? Because that was something that kept asking over and over again. I love the idea of a symposia. Like, we need to carry on this conversation. This has to be the beginning. I do want to say that Elena just put in the chat, there is a document. In fact, Dr. Baskin actually helped review and added some pieces to that. It's that if I knew I'm about to go in in to get another central line. What do I need to ask? And it's not saying you must ask these questions. It's saying you have permission to ask some of these questions or all of these or none of these if you don't want to, but it's on our website there. So we really definitely have this, the need to say, here's at least, can we have this conversation with people? It won't protect us in every way, but it's a start. Somebody asked, are you literally referring to loss of central access? Yes, people are being told you have no more access left. This is your last access. The crime is that they say that, but the really bigger crime is that we've gotten to the point where they're feeling the need to say that. We are definitely going to have to carry on this conversation another time. So I just want to say thank you for the attendees for being here today. Thank you for sitting through this hard conversation. It's a hard one to have, but I also want to say thank you to all the panelists for pulling this together. We need you. If you hear nothing else from us panelists, is that we are desperate. We need help. We need you, and we are willing to fight alongside of you. Please utilize us and to the best of our ability. Those of you who still want to share your story, info@oley.org, and we will post this webinar and the transcript of it as soon as we can. So thank you guys. Happy weekend, and stay safe out there, everyone.
Bye. Thank you.
Thanks.
Thank you, Beth. Thanks, Kevin, and everybody else. Appreciate it.